Hello, I'm Neil Resnick, the Thomas Detre Professor of Medicine and Geriatrics and Gerontology at the University of Pittsburgh, where I also serve as Chief of Geriatrics. Originally trained in internal medicine and geriatrics, most of my career has been focused on taking care of older people and also to studying the conditions that afflict them. One of the most common things that affect older people are geriatric syndromes, and of these, one of the primary ones is urinary incontinence. And so 30 years ago, we established the first geriatrics continence center in North America, originally beginning with people of all ages, and then focusing increasingly on the problems of older people. In the process of taking care of these people, we recognized that incontinence in older people was never normal at any age, even among people with Alzheimer's disease or dementia, and nor was it untreatable. But we also realized that the treatment needed to differ from what we would apply to younger people because our research showed that the causes of incontinence in older people were different. The primary issue is that aging doesn't cause any symptom, but instead it sets the stage by predisposing older people and making them more vulnerable if anything else is superimposed, such as a disease or a drug. And as a result, they are more likely to get any problem caused by that drug or disease than a younger person would because they're more vulnerable to it. So what we realized is that basically at any age, the risk of developing a symptom reflects a dynamic tension, a balance, if you will, between the presence of a new disease and its severity, which is normally counterbalanced, as you can see on this cartoon, by the body's ability to compensate, seen as the compensatory mechanisms. In younger people, the compensatory mechanisms are completely intact. By contrast, with older people, because the compensatory mechanisms are impaired, it takes less severe disease to tip the balance because the body has less ability to cope with it. But that leads to two critically important principles. The first is that disease in an older person, when it causes a symptom, may be much less advanced than it is in a younger person and therefore more amenable to treatment. And the second issue is that we can also treat these people by focusing on their compensatory mechanisms, because if we can strengthen and reinforce them, we can help tip the balance back, even so much so that occasionally we can get rid of a symptom by ignoring the new disease entirely. What we found is that normal older people are dry or continent not because their lower urinary tract is normal, but rather despite the fact that their lower urinary tract is abnormal. So half of older people have a bladder that is set to betray them. So when it gets filled to a certain amount, it can cause a spasm, which can then make them soaked. But what we found is that if everything else works fine, they're aware of this, and so they drink less, they void more often, they know where all the bathrooms are, and so they don't let the bladder fill to that point at which it triggers a spasm. But if, for instance, they then get prescribed a sleeping pill, which can cloud their sensorium, it makes it harder for them to know where the bathroom is or to pay attention to the bladder, and as a result, the bladder then fills up to a larger amount until it triggers a spasm and soaks them. So, whereas in a normal person, a younger person, the only approach would be to treat the spasm, in an older person, we can simply take away that sleeping pill, and now their brain can again focus and anticipate when the bladder will get full, prevent it from getting that full, and thereby avoid it triggering a spasm. Those two principles have allowed us to provide care and even cure for older people with incontinence, often in a more effective way than we could younger people, in whom the sole problem is the diseased organ or bladder itself. Those principles turn out to be generalizable. We found that the same approach is equally effective when we apply it to older people who have falls or confusion or who pass out or who are depressed, etc. And as a result, we've been able to vastly improve the efficacy of our treatment of older people. And because so many of these approaches are simple and can be done by any internist or family physician, they also can be less costly in addition to being more effective. And those are really the principles that have emerged from 2 decades of research, starting initially with incontinence, but now being found to be helpful far beyond that.